Okay, so any questions before we begin? Anything you guys have lingering issues with? Yes, ma'am.
None issue, but what time is this exam?
That's a good question. You should check with Dr. Hendricks.
Okay, in this room?
I'd check with. I won't be here for it, so that's kind of the thing. You're right, right. So yeah. I know it's next Wednesday. I don't know. I think it's next Wednesday.
Yeah, they put it in the morning.
Yeah, it's in the morning. Yeah, I know it's. Yeah, let me make sure the beast. It'll be okay. Then it'll be 8 to 10. Yes, there you go. All right, sounds good. All right, any other questions? Anything else? Okay, so let's get started. Basically, it'll pop up a question. You'll have some time to read it, and then you'll have basically put 60 seconds on all these questions to answer. Whatever you think is the best answer, and then we'll talk about we'll discuss it and see why that is the correct answer. So, okay, let's start. If you get kicked out, there's the pin numbers you can get back in. Okay, so which of these methods may be most affected by extremes of weight in children? So which one do you think can be most affected by either underweight kids, overweight kids? So kids that go outside the normal weight dosing. Seems simple, but
Don't do this to us.
as well, what can be most affected by the kid's weight? So if a kid that comes in, they're twice what their normal weight should be on the growth curve, like which way is going to be affected most by that, right? Right. So you may think, wait, it's weight-based dosing. Obviously, the weight is going to be most affecting that, right? Here's the tricky part with that one. So think about your age-based dosing. Think about you have a kid who comes in, they're 3 years old, and it says you want to dose this at 10 milligrams every 6 hours, right? What if that kid comes in and they are extremely underweight? What happens if they come in they're extremely overweight, right? The age-based dosing does not take into weight at all, which can lead you to have the biggest effect here, right? Where you could be underdosing or overdosing your patients, right?
So age-based is the right answer.
Yeah, so age-based would be the one because it doesn't take into account weight at all. So that way you'd have kids that could be over or underdosed very easily, right? The weight-based dosing is better, but you run into problems where when you get to like really extremes of either end, especially with like the overweight kid. Sorry. Sorry. So with the weight-based dosing, right? So that's usually pretty good for the most part, but you run into issues when you start to get really to the extremes of either end, especially on the overweight kids, where they end up having a lot of extra adipose tissue versus like just their muscle tissue and other things like that. So again, when we were talking about things like adjusted body weight and ideal body weight, they're getting kind of well far away from that. And so in some cases, you have to kind of use that adjusted body weight to try to kind of bring things back in a little bit to make sure you don't end up kind of overdosing them based on kind of their altered kinetics, right? On the other hand, do you guys remember what was factored in with along with weight to get your body surface area? Not the age of the patient. The height of the patient. Yeah, so once you start taking into account the height of it, now you can also take into account whether you have a really short kid or a really tall kid, and that helps to blunt the effect that weight has on those patients as well. So for the absolute one that will have where weight has the most minimal impact, which still has a big impact, but the most minimal impact is going to be with the body surface area because you're also using another variable to try to figure out, what's the actual size of that patient, in relation to what their height is. Versus weight-based, obviously that can be more affected by weight, but it could be on either, extreme under or overweight. And age-based is completely affected by weight, where you can be under overdosing kids very, very easily just based on their age alone. Make sense? It's a little bit more of a conceptual problem there. Okay. Moving on. So you'll see who. It's okay. So we'll see who's in the lead. So you can if you need to throw stuff at people, you'll know who to throw it at. Okay. All right. Which change could decrease the volume of distribution for a hydrophilic drug? We've seen a question like this before. Sometimes I put for these. Sometimes I'll put trick questions or more than one right answer. Just FYI. I don't do that on the actual test, but Since this doesn't count for anything, then besides personal pride. And there's some fun questions that have no point value. They're trivia. All right. Good. So most of you guys got the correct answer, right? So sometimes I'll put two right answers on some of these questions. Sometimes I'll put all four. It just depends on how I feel like tricking you guys, right? Because I can't trick you on the actual test. I'll trick you here instead. Okay, just kidding. So why would increased plasma protein binding decrease the volume distribution? Yeah, more of the drugs don't stay in the bloodstream, right? Because it's binding up to things like albumin or like alpha-1 acid glycoproteins. It likes to hang out in that central circulation, so it can't distribute out far into the tissues. Okay. Increased tissue protein binding would be just the opposite of that, where right, so you'd have increased binding of the drug at the tissue site. So more of the drug would be kind of partitioning out into the tissues. Your volume distribution go up at that point, right? Edema, why would that not be the case? What should that do to your volume distribution? Yeah, so it should increase it, right? So you're having a lot of extra fluid, like in the interstitial space outside of the bloodstream. So more of that drug's going to partition out of the bloodstream. You measure that level, it's going to be lower, right? So that's going to lead you to assume you have a higher volume distribution, which we certainly see. So think about patients who have like ascites. Which one do you get ascites? Liver dysfunction, yeah, so you see these liver patients, these are like really big abdomens. A lot of that is just fluid they're kind of building up because of like tissue protein issues or plasma protein issues. But right, so those kind of patients kind of all that drug just partitioning out to that fluid where it's not going to be able to be measured in the bloodstream, right? And then dehydration, obviously that's going to have the opposite effect of that, where you have a lower blood volume, more of that drug is being concentrated in the bloodstream, and so you have a higher level. That's going to appear you have a smaller volume distribution. Good. All right. Moving on. A 4-year-old 17-kilogram patient with dehydration presents to the ER. What is his maintenance fluid rate? You guys remember we went over this? Took my kid to the zoo today, and it was so hot and muggy outside, I thought I was going to start fluids on her. She was just dying. Get our answers in. Remember, you miss 100% of the answers you don't answer. The questions you don't answer. There you go. Okay, so how do we get the answer 54 mLs per hour? What's the rule we use? Remember the 4-2-1 rule? Yep, we covered that in the PED section, right? Pretty sure we did. So right, so remember that we are going to do for maintenance fluid rates 4-2-1 rule. So that means for the first 10 kilograms of that patient's weight, they get how many mLs per kilo per hour? 4, right? So that means for that first 10 kilograms of that 17 kilos, that patient's maintenance rate is going to be what? 40 mLs per hour, correct? Okay, so now we have this extra 7, and so for that second 10 kilograms, how many mLs per kilo per hour does that patient get? 2, yeah, so 2 mLs per kilo per hour. So 2 times 7 is 14, so we just add 40 plus 14, we get 54 mLs per hour, okay? So why do you think this is so important? Like, why do I, like, kind of hammer you guys on this stuff? So a lot of patients end up getting a lot of IV fluids, right? So you think about, like, you get admitted to the hospital, you have an IV, you're NPO for surgery or for whatever reason, or you're having gastroenteritis and you can't tolerate fluids, like you got to have maintenance fluids, right? Especially with little kids, you have to worry about them getting enough sugar, right? They're much more likely to go hypoglycemic, so you always put them on usually dextrose-containing fluids with some salt, and it's really important to get the rates correct, right? Because otherwise, you know, it's one of those things where you write the order, say, hey, go ahead and start this kid off at, say, I don't know, just 125 mLs an hour, not taking into account their rate or their weight. You let it run all night, and then you come the next day, there's no notice the kids are like really edematous, or so you're worsening the kid's pulmonary edema or something like that. On the flip side of that, you can also have dehydration that can occur from them not getting enough fluids. Yes, ma'am. You normally don't correct. You don't normally change your doses for that in that respect. So, for instance, if you think they're having like internal bleeding and they appear to have like a decreased blood volume, right? So it seems like they're getting hypotensive, they're getting tachycardic, all those kind of things. Like you're giving them fluids to replace that space, and so because of that, that drug will partition into that and then to that fluid, and so you don't necessarily have to take into account. Hopefully, you're finishing that. You're stopping that bleeding at some point, in order to account for that. That's usually probably why they came to you in the first place. But you normally don't have to adjust their dosing at all. In some cases, you may see that if their renal perfusion takes a hit, like their blood volume is so low that the kidneys stop getting perfused as well. Sometimes we'll take that into account, and if they're not clearing as well, we'll change the dose or change how often we give it. That's a good question. Cool. All right. Do you guys remember what the fluid bolus would be for a kid? What dose? 20 mLs per kilo. It's always a good number to remember. Remember that 4-2-1 rule and that 20 mLs per kilo for a fluid bolus, and it'd be golden for fluids for kids for the most part, right? Very good numbers to remember, especially when you're not on rotations. You can just come up with those answers real quick. You'll look like a rock star, right? Okay, up next. Okay, so for cocaine, not that any of you guys should do that, but let's say we're looking at cocaine. Which routes of administration do you think would have the fastest onset of action? Keep in mind, cocaine works in the brain. Insufflation, you guys know what that is? That is snorting of drugs. It's more of a, not that you're going to have to answer like this exact type of question, but certainly the concept here is important to understand. Like when people are abusing their Adderall and they crush it in order to get all the drug out at one time, they insufflate it through their nose. All right. I guess snorting was the fastest route. That's not technically true, though, so we'll look at why that is. So when you, say for instance, we were to inject a drug into the venous system, right? So you inject it into the vein, say like into the arm. Where does it go from there? Goes to the heart, right through which side of the heart? The veins are always going to empty back out into right side of the heart, right? So the inferior, superior vena cava are going to get that blood flow back to the right side of the heart, right? It goes from the right side of the heart to where? The lungs, right? Then it's going to go to left side of the heart, and then where? Everywhere, right? And then eventually the brain, right? So when you inject something IV, even though it gets into the system very quickly, it doesn't necessarily get to the site of action quite as quickly, right? On the other hand, if you're looking at something like the inhaled route, so if I were smoking this, say, like crack cocaine, which is why we'll talk about why this is so bad, but when you inhale this, it goes straight to the lungs. It goes from the lungs to where? Left side of the heart, and then to the brain. So you're already cutting out a whole venous side of things. And so that's why it's so quick to get into the brain, because it can be absorbed very well from the lungs. On the other hand, if you were, say, insufflating it or having it, inhaled through the nose, where does it go from there? No, you actually don't see just because it's physically close to the brain. Yeah, but it's very vascular and see absorption, but it's still in the venous system. So you still are in the same boat as you would be with intravenous administration. The other thing, what do you guys think cocaine does to your blood vessels? They constrict or dilate them? They usually constrict, right? So think about cocaine being like very much like your sympathetic nervous system, right? Because you see someone who's on cocaine, like they're very wired and their eyes are dilated and they're sweating and they're tachycardic and they're hypertensive, right? So they get vasoconstriction, and that same thing happens to their nose as well. So they actually end up having this effect where they limit how much of the dose they can absorb because they have that constriction there in the nasal mucosa, right? They kind of dose limit themselves. A little bit safer actually in some regards. Also, that's why you can see what they call nasal septum perforation due to chronic use, because they will chronically constrict those blood vessels. You don't get enough oxygen to the tissue, it breaks down necrosis and goes away, right? So anyway, so the ingested also be pretty slow, right? Because it has to go through the GI tract, has to be dissolved, absorbed, go through the liver, has to then get to the venous system, right? So it's a lot slower. But the inhaled route is very, very quick. That's also why it's probably the most addictive, is because it leads to having the biggest rush of dopamine, right? So dopamine is very important in that reward pathway. And so you guys covered any of that stuff yet? So you guys will learn when you kind of get to the neuroanatomy stuff. Hopefully, you'll talk about the reward pathway from dopamine. Dopamine is super, super important for that, and so that's why cocaine is very, very good at stimulating that pathway, especially when you're inhaled. It's such a big rush of it, and then it goes away very quickly, and so that's why you're always like trying to chase that initial high. That's where you get that kind of that sensation from. Cool. All right. Moving on. Let's say drug A, you're given 100 milligrams daily to lower blood pressure by 15%. And then drug B, we're given 10 milligrams daily to lower blood pressure by 15%. Which of these would be true? We've seen a question similar to this before, have we not? Right, these drugs would be equipotent. Why is that? Yeah, they're getting the same exact effect. They're just at different doses, right? So we would say, in this case, which one would be more potent? Drug B would be right because I get a lower dose gets that same effect. Now, can I say at this point which one is ultimately more effective, drug A or drug B? No, we're only looking at this one dose. We're looking at this one effect that we're seeing there. And so you may think like, well, why is this important? Like, why do we ever care about this? Well, it does come up more often than you might think. So especially if you ever go into like surgery, if you're going to like orthopedics or any kind of pain management type service, this becomes very important when you're looking at equipotent dosages between opioids, right? So opioids are a huge, kind of cornerstone of therapy for analgesia, especially after surgery or for chronic pain management. And so it's really, really important to understand what the equipotent doses are between these different drugs. So for instance, I don't give, if I give you 2 milligrams of morphine, probably feeling okay. If I give you 2 milligrams of fentanyl, you're going to be dead on the floor, right? Because you stop breathing. So you need to learn kind of what the differences between those are, and there's charts and things that will help you kind of figure out what those are. So that way, when a patient, say, comes in on oxycodone, you can convert them over to something else while they're in the hospital or vice versa. Yes, ma'am. Yeah, so you don't necessarily look at two drugs and say, oh, these two are equipotent to one another. You look at their dosing to see like, well, okay, if I give you 2 milligrams of morphine, that's probably going to be similar to, say, 25 micrograms of fentanyl, right? So you figure out what the kind of equipotent dosages are between the drugs. You may find that like certain drugs there are no equipotent dosages between the two, right? So it depends on how effective they can be in some cases. So for instance, like if I was giving you, say, fentanyl, which is a very kind of like a good hardcore kind of like opioid, like really good at pain control, and I was trying to find an equipotent dosage of, say, 50 micrograms of fentanyl to something like codeine, which is super wimpy, you would need so much of it, it's not really clinically relevant, right? So in a lot of cases, you'll find that, there are certain doses you'll say that these tend to be equipotent, but you can't say necessarily the drugs themselves are. Makes sense? And you can do this with different classes of drugs too. So for instance, if you're looking at antihypertensives, you can say that, okay, well, 15 milligrams of an ACE inhibitor like lisinopril is probably going to be equipotent to, say, 0.1 milligrams of clonidine or something like that. So you try to find kind of those, find ways to compare it apples to oranges. Okay. Moving on. Which of these drugs do you think would be considered safest? Comparing ED50s, TD50s. This test is going to be comprehensive, so it kind of covers everything we've covered.
That was not nice.
What?
That was not nice at all.
What did I do?
Doesn't let you change your answer either.
No, so you gotta have confidence.
I did have confidence.
It was misplaced confidence. That's okay. Nobody's perfect. Mm-hmm. All right, what is the correct answer? A lot of you guys put green. Wow. So why is blue the safest? Yeah, so again, 5 grams is equal to how many milligrams? 5,000 milligrams, right? So that ratio is the biggest between those two. I do this to make a point, obviously. Be careful with your units. Make sure you're looking at those sort of things. For instance, I had one doc who was writing for like post-op orders for a kid. They meant to write for 50 micrograms of fentanyl, just 50 micrograms. And they weren't looking at the computer system they put in. They just typed in 50 and did not look at what units they were dosing it in. So it ended up being in mics per kilo per dose. Okay, well, 50 mics per kilo per dose is a lot different than 50 micrograms, right? So it ended up coming up as almost like 2 milligrams of fentanyl. I called them. I was like, "You sure you want to give this much to this kid?" And they're like, "Oh no, I don't want to kill him today." And it's like, okay, I thought so. But be very careful with your units. Make sure you're looking at that kind of stuff because those mistakes can happen more often than you might think, right? And again, if you're in working in a hospital or somewhere and you're like, this seems like a stupid rule, like why do people have to tell me to do this? This is common sense. It's because someone screwed that up before, right? And you don't want to be that person again. Okay. Common sense is not quite so common as you might think. Right. Need someone to dethrone Trina. What's going on here? Okay, metoprolol or toprol is considered to be a beta blocker. How would you classify this drug? Right, so what do you guys think? It's pretty straightforward. Sometimes the questions are just as straightforward as they appear, right? So think about beta blockers. Anytime you hear like a blocker, think about things like a competitive antagonist, right? Which means it just basically sits on the receptor and then what does it do? Just sits there. It doesn't do anything. There's no intrinsic activity at the actual receptor. It just sits there. Versus something like have like a beta 1 agonist or something, or a beta 2 agonist. Like think about albuterol for like asthma attacks and things like that. Like it's a beta 2 agonist. So what would an inverse agonist be? It's actually something that would bind to it and would do the opposite effect. Clinically, they don't come up very often. There's certain drugs that you guys heard of like the GABA receptor or the GABA neurotransmitter, right? So normally it's inhibitory. It's kind of like putting the brakes on the system. There's like a certain chemical that can do the opposite effect, which would actually cause seizures instead of stop them. But clinically, we don't use those type of agents very often. Then indirect agonists, what do you think this would be? Yeah, actually, it binds to a different site on the receptor, but it causes something to be much more effective. So, for instance, if you think about GABA again, normally when GABA binds to its receptor, it opens up the channel, allows chloride to flow into the neuron, and that hyperpolarizes and prevents action potentials. You can have drugs like diazepam or Valium or Xanax, things like that will come in. It will bind to benzodiazepine receptors. Specifically that are on that channel. They don't directly open the channel, but they allow for GABA to bind much more easily to it, which allows it to be much more effective. So we consider that to be kind of an indirect agonist in that case, right? Because they're not doing the actual change themselves, but they're making it much more likely for the endogenous product to do so. Okay. All right. All right. Which of the following occurs after chronic administration of a competitive antagonist at a receptor? I only have like a certain character count, so I had to get creative with my abbreviations here. All right. So what do we call this? What is this process where they decrease the number, or I'm sorry, increasing the number of receptors? It's upregulation, yeah. So again, think upregulation happens when you have chronic kind of antagonism at those receptors. Because again, your cells want to maintain homeostasis, they want to maintain the normal balance, and so they do things like upregulate those receptors, and they're kind of chronically being blocked. If I had a chronic agonist being given, what would happen? Yeah, you have downregulation, right? You probably remove some of the receptors. You probably never see all the receptors being removed. And then when do you think this would happen? The cell would increase release of drug metabolizing enzymes. Not a common occurrence. Sometimes you can see this with certain mutations of cancerous cells, or certain bacteria will do this as a means of resistance to certain drugs. So for instance, you guys ever heard of amoxicillin, right? Or the drug amoxicillin, which is a type of penicillin. There's also augmentin, which includes a product called clavulanic acid in it. And that's what we call a beta-lactamase inhibitor. And so we'll learn when we get to the antibiotic section is that penicillins have what they call beta-lactam ring structure to it. And so that is what is responsible for the antibacterial activity. And so sometimes you'll find the bacteria will increase release of a product called beta-lactamase that will destroy that and prevent it from the penicillin from working. So in some cases, when we have things like resistant bacteria or resistant cancerous cells, we can give drugs that can sometimes block those enzymes and things like that. But again, not quite as common as up and down regulation you would see it in this kind of case. All right. A drug is removed from the market after noting increases in mortality. Which phase trial is this? So it made it to market, then it got taken off. Anyone old enough to have heard of Vioxx before? Just a few. Yeah, I can really tell I was aging out when fewer and fewer people had ever heard of that. Like, it was old like when I got into pharmacy school, and so now it's like even fewer people have heard about it. What is a very good example of a drug being removed from the market? That's a phase 4 trial. That is correct. Remember, so you do your first 3 phases while it's in, under research, and then as it gets approved by the FDA, gets out into the market, it is still considered to be a phase 4 trial. So has anyone ever taken a drug before? It says, anyone ever taken any drugs before? Yes, you have. You all have been a participant in a phase 4 trial. Whether you knew it or not, you were a participant. So, that's considered phase 4. And so we do that kind of ongoing monitoring very frequently for a lot of these drugs, especially because, if you think about the number of people that are in even like a phase 3 trial, like how many do you think? We're talking about like 100 or 1,000 or 1,000,000. Like thousands of people, right? That's it. Right? And when you give it to millions of people, that's when you find those tiny side effects that don't really creep up that often. But that can still be enough to remove it from the market if it like kills people. So Vioxx was a good example of a type of NSAID drug that did that. Other things you could do. You guys ever heard of black box warnings? We talked about those before. Those can be put onto drugs if they realize that there's an increased risk for certain populations, right? So if you look at the drug Zofran, it's really good for nausea, vomiting. Had a black box warning for QTc prolongation, right? So from cardiac arrhythmias, I got put on there. It's also a very safe drug, but certain people may be more at risk for that sort of thing. So, okay. Moving on. What type of elimination is pictured here? You were correct. It was the first order kinetic. What does first order mean? Same percentage of drug over a period of time, right? So if you're looking at this picture here, you would see that, okay, about 50% gets dropped in this 2 hours, another 50%, then, or not maybe not 50%, but it keeps the same percentage of drug keeps getting metabolized for that unit of time, right? Versus if you were to look at like something with zero order kinetic, what would that line look like? Just straight line, right? And again, this line can be straight if you were looking at the log of the concentration, right? The natural log, you would see that turn into a straight line in those cases. So if you ever see that, that's what it is. Because remember that elimination constant, that value Ke we mentioned before, right? You can see that being factored in here. That's what that Ke goes into. Basically, you start off with, say, the concentration of the drug times the natural log of that elimination constant based on time, and using that kind of equation, you can figure out, if you know where you're starting at, you can figure out what the level is going to be at any point down the road, right? You can figure out when the level becomes zero in some cases for the patient. So that can be very useful information that we'll do on our end, like if we're dosing something like aminoglycoside or something. Okay. The receptor that becomes phosphorylated then dimerizes to initiate a cellular action. What type of receptor is this? Going all the way back to that first lecture. Seems like it was ages ago. Been a long summer. Right. The tyrosine kinase receptors. Remember, that's the one that basically, think about insulin receptors or a version of tyrosine kinase receptors. Again, you have to have two molecules come in and bind to them. They dimerize, get phosphorylated, and they have whatever their downstream effect's going to be. Or G protein receptors, how those, you guys remember what they use for energy when G protein? Yeah, so use GTP. Remember that normally the subunits are inactive and they have that GTP sitting there, and then GTP comes along, gives a phosphate group, and then is able to activate that. And then ion-gated channels would be some examples of that. Calcium's a really good one. Sodium channels, chloride channels, all those are ion-gated channels, right? And then intracellular receptors, think about things like at the nucleus, think about things that like steroids are going to affect for like gene transcription, protein production, things like that. Okay. This is actually becoming much more important for, especially for like cancers and things like that, where you have tyrosine kinase receptor inhibitors. They can be very useful, and so there's certain types of cancers that we used to not really have very good treatment for, and then now this this one particular drug can just, if you have this particular receptor expressed, can wipe out the whole cancer very easily. So it's becoming much more important as time goes on. Okay. Uh-oh, starting to catch up here. Watch out. All right, some calculations. A 70-kilogram male takes 400 milligrams of a drug with a volume distribution of 2.4 liters per kilogram. What is his initial concentration? I don't have the answers. I'll do it with you. right. So pretty good. Most people got that correct. All right, so what were the steps for figuring out the answer to this problem? Okay, so you got to figure out what your VD is. So how do you figure that out?
Multiplying what you get by the kilogram.
Right, so you do 70 kilogram male times 2.4 liters per kilogram. The kilograms cancel out, and I have liters left over, right? So which is, I think, like 168 or something. Yeah. So you take that 168, and then you take 400, your dose. So remember, C0 equals dose over VD. You take you're solving for C0, so you take that dose of 400 divided by that 168, and thus you get your answer of 2.4, 2.38 or something. So remember, if you have this value here, like this is liters per kilogram, you have to multiply that by the patient's weight. If you forget that, you're going to get the wrong answer. Okay. All right. Fantastic. All right. Close game. Okay. Which of the following is true about the intravenous route of administration? All right, pretty good. All right, so what is extravasation? What is that?
Outside of the
Yeah, it's where the drug extravasates outside of the vein, right? So basically the drug leaks out either due to you blew the vein, the IV was placed incorrectly, or if there's too high a pressure or something like that. There's lots of reasons why that could occur. But that would not be just, if you were to put it into an artery, you just call that what?
Arterial?
Intraarterial, yeah. So if you have something that's like given via the intraarterial route, that's usually, and do we give things very often by the intraarterial route?
Not really.
Not frequently, no. It's not super common. A lot of times you'll have certain types of monitors that will run off of an intraarterial line. So for instance, if you're trying to figure out what the patient's, a more accurate blood pressure, you can do it based off of an intraarterial line, right? Because all that pressure is coming basically straight out from, right from there. It's a lot more invasive and it's harder to get a line like that because, again, it's a high pressure system. You oftentimes need, they usually are not as superficial as a lot of the veins. So it's more difficult, but it can be done in some rare cases. So let's see. So medications given accidentally can be easily removed. No, once it's in the system, that's it. You're done. So you can't take back what you give, unfortunately. And then it has a slow onset of action. Typically, no. Typically, pretty fast onset of action because it's going right into the system. Okay. It does have the highest bioavailability because we're guaranteed it's what? 100%, right? So it's got to be 100% because you're giving it straight into the system. Which of the following differentiates a toxicant from a toxin? So going back to our definitions. All right, so toxins are non-biologic in origin. What would be a correct, what would be an example of a toxicant? Yeah, so pesticides would be a good one. What else? Think about lead, like heavy metals would be toxicants. Think about any drug that we're giving for the most part is considered toxicant. What would be an example of a toxin? Yeah, snake venom.
Enterotoxin?
Hmm? Yeah, enterotoxin, absolutely. Botulism, yeah, so botulinum toxin would be a good one. I mentioned I was at the zoo today, so I saw some nice poisonous snakes and showed them to my daughter and which ones to stay away from. I'll tell you guys some good stories of snake bites. We dealt with a lot of those because here being in the south, obviously they're a lot more active because it's nice and hot, so we get to deal with quite a few snake bites. Yes,
Do
ma'am.
they still use the horse stuff?
We do for coral snake bites. We don't really have a good alternative to that, so we still use the old horse stuff, and it's really, really nasty.
What is it called? It's antivenom, but is there another name for it coming from the horse?
It's equine antivenom, yeah, as we call it that. So usually the stuff we use for like our pit vipers, like your rattlesnakes and things, it's called crowfab, and we get that from ovine sources. You guys know what animal that comes from? Sheep. Yeah, it actually comes from sheep. So we immunize sheep against the snake venom, and then we pull out the antibodies, spin them down, isolate them. We'll cut off a portion of the protein, and then use that as our antivenom.
Nice.
That's why it's so expensive. So for instance, so if you were to take, like, say, coral snake venom, you were to give it small doses of it to a horse, they would eventually generate antibodies against the venom. We could isolate those out, take them out, and then what you'll find is whenever you're injecting foreign proteins into a person, very high likelihood of having an allergic reaction. The bigger the protein, the more likely you are to react to it, right? So if you're dealing with a full, you guys are familiar with like the FC portions of antibodies, right? So you've at least seen what they look like, little Y shapes. So essentially what you find is that you could inject that entire horse antibody into a person, they're very, very likely to have a reaction to it, which is unfortunate, because then now they're having a snake bite and they're also dealing with anaphylaxis. It's an unintended problem that you might have to deal with. But if you can cut off a portion of that, we actually use proteins you can actually find in pineapple and like papaya. They actually have some, so if you ever look at meat tenderizers, some of them are actually made from pineapple and papaya sources, because they have those proteases that can cut off portions of the proteins. So we use that, and actually shortens it up and makes it much less likely to have an allergic reaction. So just to go down a random tangent there. But don't get bit by a snake. They say the old adage is if red on yellow, kill a fellow. I just say if it's red on yellow, run away. If it's red on black, just run away. Just don't mess with snakes when you're fine. Okay. Just in general. Okay. Going on. Let's say a 40 kilogram patient is given 100 milligrams of a drug that results in a concentration of 16 milligrams per liter. What is the volume of distribution? I can tell when you guys are thinking really hard, there's not a lot of like side chatter. Still those beta waves going on. All right. This one not quite as successful. So let's figure out how we got that, right? So what do we do first? Yeah, figure out what the VD is. So how do we rearrange the equation? So VD would be equal to dose. Yeah, so dose divided by C0, right? So that's how we can get. So we'll basically do 100 divided by 16, and we get 6.25. So the volume of distribution for that patient is 6.25 liters, but we're trying to get it back to, if you notice the answer choices are in liters per kilogram. So then what do you do with that answer? Divide by 40, and then you get the answer of 0.156 liters per kilogram, okay? So based on, if you were to look at that, is that something with a high volume distribution or low volume distribution? That's low, right, because it's below 1. So a lot of it likes to stay in the central circulation, which is why when you measure that level, it comes back at 16, right? So it's fairly high for because the most of that drug you put into the system is still there, okay? Everyone with me? Very good. All right. So look at your units, make sure you're doing the correct steps there and dividing everything out appropriately. All right. This one this is good. This one's no points. The hotness or spiciness of a pepper is rated by what scale? So you're looking at how spicy pepper it is. Is it a pain scale? Is it a Scoville scale? Child-Pugh scale? The Pemberton scale? See, like, those ghost peppers that are like, so many ever of this number. Too hot, yeah. So it's the Scoville scale is the correct answer there. Huh? No, that's just a fun trivia. I would just like to. That was for no points. Maybe I might consider doing that, but I didn't want to throw it off. Yeah. Anyone watch Food Network? You probably have heard. Yeah, it's like some Mountain Brown stuff. Yeah. So that's a Scoville scale. What's a Child-Pugh? You ever heard of that term before? Huh? Oh, you'll see it with liver dysfunction. So there's like different grades of liver dysfunction. So you'll see like class C, A, B, C, D, Child-Pugh score. So they'll look at that. Pain is just upsets.
Sounds like from that you're saying child abuse, and I'm thinking that's one way to figure out how hot a pepper is.
I hope you're not beating your kids from like, "How's pepper so hot?"
Well, I'm in my screen and listening, and I'm like, what did he just say?
What? No, I did not say child abuse, but Child-Pugh score. Yeah, so kind of a funny story. So like a couple weeks ago, I gave my dad likes spicy stuff. Older people as they get older, they tend to their taste buds tend to die out. It seems like, and they need kind of like strong flavors in order to really elicit a response. And he loves spicy stuff, so I got him. We did this little like little spice garden kind of thing. So there's like some oregano and basil, and I said, "Here's some habanero peppers. Let's grow these out." And so one of them was ready to go, and I almost thought I was gonna kill my dad because he got it, and like his throat was just like, "Okay, this is really spicy." And I was just, "Oh no, I'm gonna take my dad to the ER now. This is not good." So sometimes it can't be too spicy. It was real spicy though. No, he was fine. He got it with some water. It's fine. What we normally do is use anything with a lot of lipids in it or fats, right? Yeah, milk. So like full fat milk is a good thing. So because you'll have patients, because this is the same stuff that like pepper spray is very similar. It's like capsaicin. All these are eliciting kind of the same response. And so if you have like someone who accidentally, I remember I had one patient who called into the poison center. Their kids were playing. They're on a road trip. Kids were playing this bear spray, which is basically pepper spray, and it blew up the whole thing. And the whole family was being exposed to it, right? It's no good, but if it's on the skin or anything like that or in the mouth, high fat stuff. So everything like full fat milk or like olive oil, anything like that is good to, because the spicy components will partition off into the lipids and then it can be washed away. Yep. Sour cream, anything you want, just something with lots of fats in it. Tub of butter, whatever you like. It's like, no, I have to eat this tub of butter. It's really spicy pepper. You didn't see it, but I guarantee you. Oh, that's gross. Okay. Continuing on. Is our friend coming back? Think she's gonna. You want to wait a second? You want to wait a second to see if she'll come back? I tried to stall my tangent, but she's coming back. You guys want to wait or continue on? Yep. Okay. Wait a second or two. You want to do like a 5-minute pee break? Yeah. Go ahead. All right. Let's do that. So be back at 5:11. Not 5:12. 5:11. There'll be like 5 minutes of dead space here on the videos, just FYI. I don't do a lot of editing, so.
That and her crispy cuts of happy addiction.
What is this, jealously?
What?
I said, she says jealously, because she gets released to work.
Well, coffee coffee brings me up to alive, and then chocolate and espresso beans take me up a little bit higher. I can use it wherever you want. No matter what. Yeah. I've also experienced it on fun. Challenge accepted. Yeah, I'm gonna make you a cup and a half. We're gonna see what happens. It gives you know complication.
Try drinking a red wine.
Yeah. One time I drank a red wine and my heart started. I got like this.
Be like pasty by it.
Okay.
It tastes good. Yeah.
But I'll make you a cup of coffee. My coffee. Okay. Espresso with lemon. Yeah. So my coffee is about half caffeinated espresso.
Justin.
Better now. It's really good. They have like all the meal names.
Is that everyone? Looks like it. All right, it's 5:11. Let's continue on. Let's find out who is the. Actually, oh man, Train's pulling out ahead. We're gonna have to do some catching up here. We're making it competitive. But Evil Morgana's coming up. We cannot let evil prevail. That's the only thing we cannot let happen, right? Okay. Which of the following categories has the least amount of abuse potential? So regarding controlled substances.
What? I had to read again. Hold on, but I
This is not child abuse potential. This is actual drug use potential. Just FYI. All right. What is Schedule 1? Yeah. So that one has the highest abuse potential, but no acceptable medical use. So marijuana is still considered federally still a Schedule 1 substance, right? As opposed to something like cocaine, still has a very high abuse potential, but has an acceptable medical use. That would be a Schedule 2. And then you go just down the line from there in regards to abuse potential. So Schedule 4 would have the least out of this group. Schedule 5 would have even less. Okay. All right. In Phase 1 trials for a new drug, who are the test subjects? All right, that would be patients without the disease state. So remember, think about phase 1 trials as being the very early ones. What are we looking for in terms of the drug? Are we looking for efficacy? Yeah, we're looking more for safety. We're not looking for efficacy because we're not even using it in patients who have the disease state, right? So these are healthy patients otherwise. So you're looking for pharmacokinetic information. You're looking for safety information. When you move into phase 2 and 3, then you start to deal with the patients who had the disease state, right? And just in larger and larger numbers at that point. You're still looking for safety the whole time period, but now you're starting to look for more efficacy as you get further on in phase 2 and 3 trials, right? Is it phase 4 is when it comes to market, everyone who's taking it is now a participant. Now, when do laboratory animals get involved? Preclinical trials, right? So, if it causes mice to grow a third arm or something, we'd say, maybe that one's not great for people, right? Let's avoid that one. How about pregnant patients and children? Very difficult to do studies in these patients. They are a protected at-risk group. It is unethical to do studies in a lot of pregnant patients, or it's very difficult to do ethical studies in those groups. Guessing of any other at-risk groups of patients? Or people who maybe not able to consent on their own might be one. Not necessarily all geriatrics. In some cases, if they're cognizant and they're able to give consent, that's not. The other big one's prisoners. Like you can't do trials on prisoners just because they're a captive audience, so to speak, right? Because they are you can't say they might get the idea that if I do this study, maybe I'll get out of jail early or something. That you can't do that. So unethical to do studies in prisoners. Okay. There are some cases where you may not go that normal route. So have you guys ever heard of an orphan drug? Sounds bad, like his drug parents were killed and now it's turning into drug Batman or something. Not the case. This is for disease states have a very small number of patients who are ever going to have this. So think for instance, like coral snake bites. Like we're coral snake capital of the U.S. and we only have maybe 50 bites a year, right? So it's a very small patient population. Think about rare genetic conditions where you don't have a ton of patients who have the disease state. It's very difficult to do trials. You can't do thousands of people who have that disease state because that might be everyone who has it, right? So in those cases, you may find some more expedited routes or things where you may be giving drugs earlier for what we call compassionate use because there may not be any alternatives to that drug. So we do that a lot with certain genetic conditions we have over like Nemours because there might not be any other therapies for these kids and they have pretty debilitating or life-threatening illnesses. So anyway, so you might hear that term orphan drug and that's what it refers to. Okay. Inhibition by CYP3A4 by grapefruit juice would cause which of the following outcomes? So would you say that simvastatin is a substrate of CYP3A4? So if you were to inhibit CYP3A4, what do you think would happen? Ooh, almost a 50-50 split there. So why is that the correct answer?
CYP3A4 metabolizes the drug, so you inhibit it, it'll increase serum concentration.
100%, yeah. So if you have a drug that is a substrate for a CYP enzyme and you inhibit that enzyme, levels are going to go up because you're not metabolizing as quickly. So in this case, you'd have elevated levels of simvastatin, and you can see side effects are associated with that. For this drug in particular, hepatic side effects are really big. Rhabdomyolysis is another big one, right? So you ever have a patient who comes in, they're like, yeah, man, I started taking that Zocor, and I just taking it normally, and all of a sudden it feels like I ran a marathon. I haven't even gotten off my couch this weekend. Like that's usually one of those things where like you're thinking rhabdo and having muscle breakdown. On the flip side, though, if you had a CYP inducer, that would drive up levels of the enzyme. You would have more of it available to metabolize the drug, and that would drive levels down. Okay, so keep that relationship in mind. If you induce the enzyme, you will lower levels of the drug because it gets metabolized more readily. Yeah. Okay. All right. What is the standard expiration dating for a prescription for a non-controlled substance? So if I write a prescription today, how long is it going to be good for? Well, not me, maybe you guys one day. I use in 2 years. You write one. All right, yeah. So 1 year is the correct answer here. When is it 6 months? Yeah, everything except for the C2s. Remember, C2s, like, you can't really get any refills on anyway, so, like, the expiration doesn't really matter. So it really doesn't need to be filled pretty quickly after they're written. But 6 months for 3, 4s, and 5s. Obviously not 30 days or 10 years. So no point in holding on to old scripts that people don't have filled, because if I take it to the pharmacy, even if I take it the day before it expires, hand it over to them, they're only going to give me that one fill, and that's it. The rest of the refills are no good at that point, right? So again, just a year is the standard. And then what do you think the date is we put on the bottle? Like when you actually fill your prescription for that month, like what's the expiration we put on there? Yeah, it's not by the number of pills. We actually just put a year on that as well, right? So when you get a pill bottle, normally it'll say a year, unless the drug expires before then, and then we'll put that shorter date, whichever one's shorter, basically. So that's why if you ever go and fill something, look at the expiration date on there. I know it's probably something you guys never looked at before, but look at it, and it'll be a year from whenever you filled it.
I thought that was when the drug expired.
Right, so you think that's when the drug expires? That's not actually true. A lot of times the drug itself will have longer expirations. Drug expiration dating is totally kind of bogus in a lot of cases. So, but we'll probably talk about that at some other tangent. Okay. Which of the following has an inverse effect on aqueous diffusion across a biologic membrane? So if I increase this value, I'm going to decrease the amount of diffusion. All right, awesome. Yeah, so thickness of the membrane there, right? So if I increase the thickness of the membrane, so imagine going from like a pediatric patient's skin to like an adult skin, that increased thickness does what to the amount of drug, say flux I would have? It would go down, right, in a lot of cases. Other things, if I increase surface area, that would go up. If I increase the lipophilicity of the drug, that goes up. If I increase that difference in concentration, again, that will go up as well, right? So that's the only thing that's really inverse to that. Right. Which of the following is not required but recommended on a prescription for safe use? All right. Okay, so let's examine this. So provider signature. Is required, right? You have to have a provider signature on there, so you have to have that. Strength of the medication. Have to have that on there as well. We can't fill it unless we have that information. Medication brand name. You don't, yeah, it's not required necessarily, and it really doesn't help us out a whole lot. So always want to put if it's like an extended release product or not, but you don't necessarily. A lot of people don't put the brand names for drugs unless that's all they know it as, and then sometimes they'll put they'll just put it as the brand name. But again, we're always substituting with generics if it's appropriate based on laws. But the PRN indications is a huge thing there, right? So again, you can get away with a prescription that just says hydrocodone, acetaminophen, take 1 tab every 6 hours as needed. Okay. Question is, what is it as needed for, right? So is it as needed for pain that's not relieved by ibuprofen, or is it, the patient needs clear understandings of that. Right, so you need to have some kind of clarification on that, especially with Joint Commission becoming much more kind of heavily focused on that sort of thing with therapeutic duplications. You need to have qualifiers on there. So it's just good practice to say, especially the patient knows, and it's on the bottle, when they should be using this as needed. What constitutes the need, essentially. Okay. All right. How long does a drug company have on a patent to make their money back before it expires? Yeah, the patent is good for 20 years. Now, will they be able to market it as a brand name drug for 20 years? Yeah, because that 20 years includes all that time in clinical trials, right? So if they make it out of the FDA with only, say, 5 years left on that patent, that's all the time they get to be a brand name before it goes generic. Okay, you get 20 years is the number. All right, so last one. Why do graded dose response curves exhibit a plateau at the upper end of the doses studied? Yes. No, they'd have to make a new drug. I'll talk about that in a second. Yeah. All right, perfect. Yeah, so again, when all the receptors are bound, that's when you get that plateau effect. Because even if I increase the amount of drug that's around, there's no more receptors to bind to. Glad we went out on the bang. What is that tachyphylaxis? What is that? Yeah, so like, right. So even if I increase the dose, you don't see any increased effect, and that's due to usually depletion of cofactors, or there's some kind of counter-regulatory thing the body's doing to prevent that effect. Yeah, so it's not a common one, but we talk about nitroglycerin being kind of a very common example of that one, where you do 12 hours on, 12 hours off. That one is a reason why to prevent that tachyphylaxis. Perfect. So you mentioned in the patents, sometimes what they'll do is they'll try to market just a little different variety of the drug to try to get a new patent on that. So if you ever see, there's that one example I was talking about with the enantiomers, right? Yeah, I remember that I think it was like descetirizine or something like that, and they're like, the clinical importance of descetirizine has not been shown, and we're just like, well, why are you marketing it as a new drug if you have no idea why you're doing that? The reason why is they get a new patent on it. Yep. Mm-hmm. Well, maybe not ethical, but moral. I don't know. Yep. Anywho, okay. Our winner, Trina. Congratulations. Next up, Thor. Fantastic. And then Kolbs. All right. Good job, everyone. You're all winners in my heart, though. Okay. Any other questions I can answer before we adjourn for the day? Do you guys like this? That's fun? Okay, good. I'll probably end up doing these for all of Pharm 1 and 2. Yes, ma'am.
Could you elaborate more on, for instance, if you have 2 different doses of enantiomers,
Mm-hmm.
what, just that concept?
Yep. So if you think about a racemic mixture, is going to be 50% the left-handed molecule, 50% the right-handed molecule. If I were to isolate out one of those enantiomers, because maybe that's the only one that has the physiologic effects I'm looking for, then I could use that as a new therapeutic molecule, right? So for instance, if I have 40 milligrams of the racemic mixture, the equivalent dose of the enantiomer would just be 20 milligrams, right? It's just half of that. Yep. So as long as you keep that relationship in mind, and we do that a lot for patients who are coming in on certain drugs we may not carry. So for instance, they come in, say they take escitalopram, right? The parent drug is citalopram, which we carry. So we would convert them, say, from 10 milligrams of escitalopram a day over to 20 milligrams of citalopram. Any other questions? All right, well, good luck on the test next week, and I believe I'll probably be seeing all of you for Pharm 1, unless you guys all get me fired in the meantime. So, we'll see. Thank you.
Thank you.